All right. I'm here. I am late. I'm actually kind of late, a lot later than I normally am, but I am here. Okay. All right. We had some fun tonight in our household studying for math test tomorrow, so had to get that last minute studying done and helping the kids out with that and getting everybody shipped off to bed. But I am here. I am here, folks. All right, guys. I'm going to give you guys a couple minutes to jump on board this evening and collecting my notes here. All right, guys, as you jump on board, give me a shout out. Let me know who you are, where you're from, what's in your mug. Want to hear from you guys tonight. Cheers. We'll get this started right. Guys, let me know if you can hear me okay with my microphone, please. And those of you watching the replay, please, if you don't mind indicating replay in the comments section. I always like to look back on the comments and just see who's in the replay, and also to see if there's any extra questions that may have come in from folks who are watching the replay. So we've got Steven coming on board. Hey, Steve. We've got William Mays in the house, Eric Crump. We got Brian Bishop, Bustelo once again. Oh, Brian, I only had time to put water in my mug, so I really would love a Bustelo right about now. Hey, Harsh, how you doing? We got Brett in Kansas drinking his water. You can hear me good. Oh, awesome, guys. And Eric is in Tennessee seeing Ronnie. Oh my gosh, Eric, you have got to tell Ronnie I said hello and tell him I'm going to call him about a really important project. So just put that bug in his ear for me. We've got Lee from Fort Myers, Trent coming in from Colorado. We got Benny from Texas. Benny, man, that brought back some memories. That Selena clip that you sent me this morning, that was pretty cool. Hey, Bonnie, drinking coffee in Tennessee. I really miss my coffee tonight. I was working hard with one of my kiddos. She has a big math test tomorrow. So we literally have been working math problems up until the last second. So I didn't have time to put on my decaf coffee, which I would really love some right about now. Let's see, we've got Sandra coming in from Gainesville, my other Floridian there. Audio is great. Thank you, Sandra. We've got Jody coming on board from Las Vegas, drinking Cherry Crystal Light. Ooh, that sounds good. Susan, oh, Susan, please send me an update. Please send me an update. You are never far from my mind. We got Stephen McCarthy. It's been a few weeks since I was on. I'm glad to have you back, Stephen. Dick Devers with his Miller Lite in West Virginia. Awesome. Johnny V. Oh, Johnny, thank you so much for your time with me today. I really appreciated all of your input. And fingers crossed that the internet's going to behave tonight for us. We've got Brett saying his prosthesis has been delayed until Friday. The anticipation, right? The anticipation of getting that new leg. We've got Lonnie here from New York. Lonnie, your name looks very new to me. So if this is your first time, welcome. We've got Daryl with his lemonade. Mark S. Mark, you and I need to have a conversation. So reach out to me because I have mom brain, but you and I need to have a conversation. There's something I want to ask you about. We've got Kenny, who's got a new socket tomorrow, a little rum and Coke in my glass. Dude, Kenny, that sounds awesome. Hey, quick Cosi poll. How many of you have a Cosi Talks mug? Can you just type it in the comments section like I have one? Let me know. Just a quick random poll, whether you've won one on a free giveaway or you bought one off my website, I would love to know. We got John Gildane listening in from Valparaiso, Indiana, and enjoying a pizza and a beer. So good. Guys, y'all can tell I had a long day. Hey, Andrea, no drink, just brush my teeth and getting ready for bed. All right, then, yep, all bets are off. We've got R.L. Dotson here with Juan Valdez, Arkansas. Ooh, okay. We've got Lori from Toledo with water in my mug, just over 2 weeks post TMR surgery. No spirits for you, Lori. So, Lori, I would love to hear how it goes for you with TMR. So guys, TMR is targeted muscle reinnervation. We did a really nice show a few months back with Dr. Leonard Dedesi about targeted muscle reinnervation. So for those of you who are not familiar with that procedure, allow me to explain. With amputation, typically a surgeon will pull a nerve and then transect the nerve as he or she is cutting the rest of the leg. And then the nerve is allowed to go right back into the soft tissue. Well, unfortunately, that nerve can sometimes get into trouble because scar tissue will form around it. And idle hands make devil's work, right? So that nerve that's kind of floating around in there starts to cause problems with serious pain issues and sometimes really triggering some pretty bad phantom pain as well. So with TMR, targeted muscle reinnervation, the surgeon basically takes that floating nerve ending and plugs it back into a specific point in the muscle so that it has a job to do again, right? So it's a really fascinating procedure. It's been around for actually 20 years. It was originally created to help upper extremity amputees get set up for their prosthesis, the mind control. We like to call them the mind control prosthesis, the myoelectric prosthetic devices. And now it's starting to trickle down to the lower extremity surgeries. So it's exciting. And the reason why I'm kind of like really babbling on about this is because Dr. Dedesi has agreed to come back onto the show. So he's going to be in the hot seat in July. I don't have my calendar with me, but it'll be up on my website soon. So he's going to come back and give us a refresher course on targeted muscle reinnervation. And he's going to give us a talk also on RPNI. And heavens, I've got mom brain to the max today. It's regenerative peripheral neural interface. Oh dear heavens, don't quote me on that one, guys. It's a similar procedure to TMR. So we're going to be talking about both of them. And obviously, I've got to do some reading up on my own about it too. So look for a show in July that we're going to be doing with Dr. Dedesi. I'm so excited. I love having special guests on the show. All right, I need to stop talking. Let me read some of these comments. Ashley, yeah, I've got mom brain. So when it comes to doing math after 4 kids, I'm just like, ugh. For those of you who don't know me, I have 4 beautiful children. So yeah, by the time I get to number, the 4th kid of math, my brain is just gone. Olguita, oh, ¿cómo estás, mama? We've got Erica on board. Rita, my girl, I got your question right here, darling, and I've got something special for you to answer your question for tonight, Rita. Herman, it's been a while. Yes, I'm glad to have you back, Herman. I saw your name. I was like, I haven't seen your name in a little while. We've got Jim working fine and enjoying the show from Illinois side of St. Louis. Staying alert with black coffee. I need some of that right now. Rita in Michigan. Comadre. Yes, Mark, I'm talking to you, sir. Yes, sir. I need to speak with you hopefully soon. Keitha, darling, it has been a long time since I've seen you. It is so nice to see your bright face, Keitha. All right, guys. So for those of you, I should probably introduce myself, right? For those of you who are first comers to the show, welcome. My name is Cosi Belloso. I'm a physical therapist, amputee specialist here in bright, sunny, hot, sweaty, sticky Florida. I've been a PT now for over 18 years. 18 years. 18 years. And I have a clinic here in Tampa called Palanca. And my clinic here is exclusively for working with the amputee and limb loss community. I recently posted, I don't know if you guys got a chance to see it, but I recently posted a video yesterday just telling a little bit about myself. I have a wonderful tech team. So she likes to get me to refresh my content on my website and keep things up to date. So I recently just put out that video to my Facebook page. And for those of you who have helped me spread the word about what I do, and I truly appreciate that, this is a video that just kind of explains who I am and what it is that I do. So if you want to share it to your support groups, feel more than welcome. I would be very much appreciating the support there. I'm trying to see if I can call that video up right now, but I'm having a hard time doing that while doing the show at the same time. So let me just focus on doing the show. All right. So you've tried to buy a mug, Steve. Sandra has a mug. John does not have a mug. All right. So guys, I ran out of mugs. I ran out of my Cosi Talks coffee mugs, but I was able to find the same manufacturer who made them, and they are sending me new mugs. And I also ordered something fun for summer. So something that will help be suitable for cold drinks. And I can't wait to show it to you. It's just little things in life that make you happy, right? Let's see. Johnny, he doesn't have one? Yes, Johnny, I definitely need to get one to Greg. Yes, Andrea, I'm glad they do hold a ton. I like my big coffee mugs. I'm like, if you're going to drink coffee, drink coffee, man, not these little tiny mugs. Barbara, oh my goodness, glad to hear you. Patricia, thank you so much. And I appreciate your being here. Olga says, why don't they do that as they are doing the amputation instead of waiting until we have issues? And she's referring to the targeted muscle reinnervation. Olga, that's a fantastic question. Main thing is not every surgeon is trained in this, right? So you've heard me talk about the show. I'm kind of a history buff. I love history, and medical history especially fascinates me. The unfortunate thing is that amputation technique, the surgical technique, really hasn't changed a whole lot since the Civil War. Actually, even prior to that, it hasn't changed a whole lot. And those of you who kind of keep tabs on my Facebook page, you know that I was in St. Augustine a few weeks back, and I was able to tour the Spanish military hospital, right? And I was able to sneak in and do a little quick live feed before I got kicked out. Oops. But during the live feed, you were able to see, the surgical techniques that they were using in the 16th through 1700s in St. Augustine, the Spaniards. And it was very similar to what we do today, except today we have better anesthesia. So, Olga, a lot of the surgeons are still, coming around to the research. That's another thing. So, TMR has only been around for 20 years, and that might sound like a long time, okay? But in medical and healthcare world, it's not a lot of time. It's, they're waiting for the research to come out and the outcomes to come out to see the positive or negative effects of a new surgical technique. So that's kind of another reason why I think it hasn't caught on as quickly. And it was meant originally for the upper extremity amputee. So the trickle down effect takes a little bit of time for things to kind of get moving. But Olga, I think we are going to start seeing a lot more TMR surgeries. And I think we're going to start seeing more surgeons training in this because they're starting to realize that, and again, I haven't read anything official. I'm not quoting any official research, but just the practicality of it, give the nerve endings something to do instead of just forming scar tissue and creating a mess, right? And then, in the future, we are going to start seeing myoelectric devices for the lower extremity. That technology is going to trickle down. And it's in the horizon. It's coming, right? So the TMR surgeries are going to be great for preparing folks for some of these devices. Now, then that's again one of my other reasons for bringing folks like Dr. Tedeschi on the show is to help, empower you guys with this knowledge. So a lot of times, folks don't know to talk to their surgeons about TMR surgery. So we can put the power in your hands, and so that you can take it to your surgeon, especially if you're facing a revision surgery, or if you are having a lot of problems with a neuroma. This is something that you can take to your surgeon and say, hey, is this something that you are trained to do? And if you're not, can you point me to a colleague that is trained in this? And when surgeons get requests and things like that, then it makes them go, maybe I should look into getting trained for this surgery. And that's how we get some progress there. So just putting that bug into your ear. And again, not everybody is a candidate. So again, this is, opening the conversation with your surgeon if this is something that you feel you might benefit from. Lori says they removed a neuroma the size of a walnut. Ouch. My phantom pains have completely changed and greatly improved already. And Lori, for the most part, with dealing with neuromas up until recently, there were some doctors out there. For example, I have one PM&R doctor in St. Petersburg who's real good with her injections. Like, man, she knows how to get that neuroma. And the couple of patients I've had from her or in common with her that have had the injections have had marvelous results. And I think it's just simple lidocaine, but I guess just how she's able to inject it just right and she gets it well. But yes, some people have to have it surgically removed. That is just, like you said, a walnut size ball of tissue and nerve endings that gets hot and bothered, and removal is what has to happen. The thing with it, and in some cases, when they remove that neuroma, if they don't tidy up that nerve end properly, it can reform again. So I think this is where TM&R is going to be a very good tool for us. Rhonda says you want the mug and use it every morning. Awesome. All right, guys. So I ordered mugs. Okay. They sold out and I ordered them. So when I put them up on my website, y'all need to go get some mugs because I don't have a whole lot of room left in my garage. Hey, Robin. Oh, I'm so glad you're here. Herman, please put the questions in. It was kind of a quiet week. I was a little disappointed, guys. Not too many questions came in. I've got a couple of good ones here. So, show me some love here. Send some questions my way. Robin, oh my gosh, Robin, you're hysterical. She says, order some right hand mugs. Guys, no joke. I'm obviously a lefty. I didn't realize that when I ordered the mugs. Yeah. So that's just the Cosi Talks flair. That's what we're going to call it. If I didn't realize I had done it. Okay. Yep, I'm getting something for cold drinks, Lee, and it's pretty. It's pretty. Okay, so let's tackle another one of these questions. So this question came in from Rita. Rita, since you're here, and let me get a video, Rita, that I found just for you. Please hold. All right, we got this here. Paste. All right, here we go. Oh yeah, I'm getting fancy. Posting in the video clips here, guys. Okay, so Rita asks, I am a right above the knee amputee. Weather is finally getting nice enough to go outside and work in my flower beds. Can you suggest an easy way to get up and down? Yes. So guys, I'm a huge proponent of teaching folks how to get up and down off the floor post amputation. Okay. Why? Because we fall. At some point in your life, as an amputee, whether you're using a prosthesis, whether you're in a wheelchair, okay, people fall out of wheelchairs. My patients have done it. I don't know how they do it sometimes, but they manage to fall out of their wheelchairs. It happens. Falls happen. And you need to know how to handle that, okay? So whenever I have somebody who comes into my clinic, that is one of the functional components that I will ask them about. You know, I'll ask them, okay, how were you before your amputation? Were you able to get up and down off the floor on your own? Okay, and that's usually a good starting point. If the person tells me, yeah, I was able to get up and down off the floor, it was a little troublesome because my leg was about ready to be amputated and it was troublesome and hurting, but I was able to do it. Then I know that with that individual, that is definitely going to be a goal, that they be able to do that as well, whether they're below the knee or above the knee, okay? Even with my bilaterals, guys, even with my bilaterals. Now, if the individual comes to me and they say, you know, before my amputation, I really wasn't moving around a whole lot. I had a lot of difficulty walking. There was no way I was able to get up and down off the floor. Then that changes things a little bit. It's not to say that we won't perhaps try a modified way of getting up and down off the floor, but it might be more about teaching the individual how to instruct their caregiver or how to instruct someone to help them get up off the floor. Okay. And I know many of you have mentioned that sometimes your physical therapists are a little bit hesitant to want to teach you this skill. Okay. And it's a little bit of a scary skill to learn. And sometimes as a therapist, you're going, oh, geez, all right, we're going to do this, right? So, you know, with therapists, especially when I have younger therapists come in, I say, as long as you can provide a safe environment to try and troubleshoot, you should try this with your patients. And for those of you who you know are trying to learn this skill, it's creating a safe environment that you can troubleshoot, because there's so many different ways to learn how to get up and down off the floor with a prosthesis, without the prosthesis. Okay. So Rita, the link I just posted for you right now, okay, is by Mission Gate. Mission Gate as in Mission, G-A-I-T. If you guys have not checked out their YouTube channel, you need to check out their YouTube channel. It is phenomenal. Mission Gate was founded by a physical therapist named David Lawrence, and it's this beautiful organization that is dedicated to education. I mean, we're talking like Cosi Talks is here with education, Mission Gate is up here, okay? And they have put together beautiful videos on YouTube. A couple of my videos are on there too. So you got to check those out, okay? Beautiful videos on everything related to amputee. And while most of those videos are geared towards clinicians, these are videos that you can easily access and learn so much from. So the videos that I put up there is exactly that, teaching folks how to get down, up, and off the floor. And you can see David Lawrence, he's the physical therapist in the video, and he's teaching an above the knee amputee. Okay, so for those of you who are my below the knee amputees, the technique would be the same that you can try. And he does a couple of different techniques, which is what I really like. Okay, so Rita, take a look at that. Here's the thing I would suggest though, if you've never practiced getting up and down off a floor, If you're working with a therapist, try to practice this in the clinic, mainly because we have equipment there that can help you. We have padded flooring, or we have those elevated mats that you can try it on in case things don't go well and you need some help getting back up again. I wouldn't try this for the first time on your own at home by yourself. Also, if you have someone who is helping you, your caregiver, you want to make sure you're protecting your caregiver. And David, in this video, he gives you very specific instructions on how to talk to your caregiver or the person who's helping you get up off the floor if you need that assistance, because you want to keep yourself safe, and you also want to keep the person who's helping you safe, right? Okay, one little Cosi hack that I want to add to this, especially Rita, since you're wanting to get back out into the garden area. Sometimes with folks, I use the approach of scooting up into a chair. And I've used this a lot with especially with my bilateral above the knee amputees. Okay. So particularly someone who has, good upper body strength, I might teach them, right, to lower themselves on the floor using their arms, right? And then when they get back up into a chair, that they basically lift themselves up like this. I don't know if you guys can kind of tell the motion that I'm doing. I know it's a little strange. Okay. So Rita, if you're learning to get up and down and you need kind of an in-between, if you take a chair with you out into the garden, right? Just a folding chair, a chair that's sturdy enough that you can kind of lower yourself into the grass. Okay. And then also when you're getting back up, you have something that you can hold on to. So I've done that for some folks, especially when I worked home health sector. I worked home health for over 8 years. And teaching people how to go back out into their gardens was a functional skill that I used to do a lot with folks. And I would tell them, okay, let's bring a chair out in case you get tired or in case you need to grab onto something as you're getting up off the ground. Okay. So I saw some comments come in. Let's see what's coming in. And okay, so Lori says, I was told that it was microsurgery for the TMNR, not TMNR, TMR surgery, and often only certified surgeons are plastic surgeons. Not necessarily the case, Lori. For example, Dr. Dedesi, who is a surgeon who has done TMR, he's an orthopedic hand surgeon. So, as far as surgeons who perform amputations, it can be anybody from a general surgeon, a trauma surgeon, plastics, but not typically plastics. Plastics might come in if there's a complicated wound skin flap closure. That's usually when plastics will get pulled in. The orthopedic surgeon, vascular surgeon is another one that might sometimes do an amputation. An oncology surgeon, will also, usually oncology orthopedic, folks who deal with the sarcoma population will also perform the amputation. And I've seen, as far as the TMR surgeons, it's basically when they go to get the appropriate training to do something like this. All right, Kenny. So it looks like the cold drink cup will be hopefully a big hit when it comes in. Olga says, in BKs, why leave the fibula if it causes so many issues? Just chop that little sucker off. You crack me up, Olga. All right, guys. So let's talk a little bit about our fibula here, okay? So we have our right foot. Hey, Bob. By the way, guys, this is Bob. Those of you who are new to the show, he is my reluctant model, and he comes in many different forms. As you can see, that one over there is hiding in the bushes. And I have several Bobs here that my viewers have sent me over the past couple of years. So this is my favorite Bob to use. So Bob here has his tibia bone. That's the shin bone. That's the biggest bone right there. And then this tiny little bone right here is the fibula. It is a very small bone. It actually only is responsible for 10% of accepting your body weight. So yeah, in some ways, it's really not that big of a deal bone. So when they do a transtibial amputation, a below the knee amputation, the surgeon will basically cut here, and they might bevel it just a little bit to make the fibula a little shorter, a little bit here. Everyone has their own surgical technique. But yes, the fibula is left intact. Okay. There is one surgery called the Herdle Procedure, and it was created by Dr. Herdle, E-R-T-L. Okay. And what he does is he creates takes a piece of bone, usually probably from the hip, and grafts it so that the two bones are grafted together to form like a little bridge here. And that allows the person to then be able to put weight on the end of that residual limb. Okay. So why do we keep the fibula, Olga? That's actually a really great question. And this is just me thinking off the top of my head. Basically, it's one of those, if it ain't broke, don't fix it kind of thing. You do have a particularly sensitive nerve that comes over the head of your fibula, and it comes down through here. So if you were to remove the fibula, you could possibly cause nerve damage there. But if you think about it, ironically enough, that nerve, it controls the foot. So if the foot's no longer there, right, do you really need that part of the nerve? But you have, it's basically a structure and also the bony structure there. So for socket fit, it does help to have everything there in place. And Olga, I'm going to look that up because I think there's more to that I can add for later on. Can I have you send me a message, Olga? Can you send me that question in a message so I can make sure to follow up on that? Brett says, never heard of TMR before you told us. And again, Brett, it's a surgery that's been around for a while, but not many people know about it, right? Or know to ask about it. And it's one of those things where, you know, unfortunately you have some folks who were traumatic amputees and, you know, because of a horrific car accident or any other kind of accident, and they had the accident and then woke up without their leg. So obviously they had no chance to prepare or talk to their surgeon about what was going to happen to them. But for most amputees, you have the ability to talk to your surgeon prior to your amputation and ask these questions, and especially those of you who are getting revisions done. So I would encourage you, have that conversation. Just see, am I a candidate for this? You know, have that conversation. Every amputee should buy a file for their surgeon. How they miss rounding is beyond me. Daniel says, how come the Herdle procedure is old but hardly talked about? That's a very good question, Daniel. I'll be very honest. I've only seen a very small handful myself of folks who have had the Herdle procedure, and just as many folks that had positive results, that they had the same results as a person with a traditional amputation. I think part of that, again, it's also, you know what, Daniel? I don't know. I don't know why it is that we don't hear more about the Herdle procedure, but you've kind of piqued my curiosity to see if I can find out why. Could it be that because it is a newer, not newer, a different surgical technique than the traditional amputation technique? It does require more skill on the surgeon's part because they have to be able to create that bony bridge with the bone graft there. It would theoretically be a longer healing time because you have to wait for that bone to heal completely before the person can start putting weight into it. Okay. As far as the results are concerned, I don't have official results on the outcomes of the Herdle procedure. That's something I'd have to look up in the literature. Like I said, just from hearing in the community and having patients and people who've had Herdle procedures, I've heard from both sides of the coin. Daniel says, I have the Herdle and hardly ever have pain or sensations. Let's see. Oh my goodness, Kay, watching from Hawaii. That is one of my favorite places on earth. Susan, TMR is targeted muscle reinnervation. Herdle doesn't stand for anything. It's simply the name of the physician who created that surgical technique. And guys, you can go back into the archives on my Facebook page, on my video library, and you can find where I talk about the TMR. Yes, Ashley, I think that lefties do rule. There's my lefty right there. All right. Lee says, what percentage of amputees decide not to get a prosthetic? Lee, I don't have an exact number on that, but it's more about prosthetic abandonment. And that's something that the percentages are fairly high. So folks, folks who do get, and actually, Andrea, if you have any numbers on that, I would love some help right about now. What I hear more about is the prosthetic abandonment, meaning the person goes and gets fit for their prosthesis, but they end up never using it. And it ends up sitting in a closet collecting dust. And there's a few different reasons for this. Socket fit. If the socket doesn't fit comfortably, the person finds it easier just to use a walker, crutches, or a wheelchair. Energy expenditure. Okay, it takes an exorbitant amount of energy to use a prosthesis. as a below the knee, someone who's a below the knee, they are using anywhere between 20 to 40% more energy to walk than a person with 2 anatomical legs. And the percentages go up from there as high as 80% for an above the knee amputee. Okay, so the amount of energy a person has to use. Follow up, and that's where my personal soapbox like explodes all over the place. How many folks get their prosthetic device delivered and then they have no physical therapy? So they have no one to teach them how to use the prosthetic device. And as all due respect I have to the prosthetists that I work with, they are not trained to do gait training. That is physical therapy, right? Prosthetist builds the car, PT teaches you how to drive it. Okay, so if you don't get driver's ed on your leg, your chances of using it successfully for a full day, all day, every day, greatly decreases those chances. Okay, now the literature says, can anybody guess what's the #1 reason for prosthetic abandonment? Jeopardy question. This is like the final Jeopardy question, guys. RIP Alex Trebek. All right, what is the #1 reason for people abandoning their prosthetic devices? Let's see who can answer that question. Brett asks, is it possible to shift a motorcycle with a left above the knee amputation and a prosthesis? Woo, it's been a minute since I've been on a motorcycle. In fact, it's been like however many years since I got married. My husband used to have a motorcycle, but once we got married and realized that we kind of needed each other, we got rid of the motorcycle. So it's been a while. I do have some motorcycle riders. I know that a couple of them get hand gears to do everything in the hands, which if I remember vaguely, there's something about changing gears in the hand. I don't believe I've ever seen a left above the knee change the gears with their prosthesis. But again, it's been a while since I've ridden a motorcycle, so I may not be the best individual to ask that question. I would say, Brett, hand modifications might be needed for that. Any motorcycle riders here want to chime in for that one? Kay says, I use a portable garden bench. You can sit on it or flip it over and kneel on it, and it has the handles to push yourself up on. I like that. That's fancy, but I like that, Kay. Let's see. Susan says, I crawl to something and pull myself off the floor. I can't just get to something without holding on to something. Yeah, and many folks, they end up using that technique, and that's perfectly fine. Let's see. Jennifer, glad you could join us. Yes, Mission Gate has fantastic video content. Fantastic. Let's see. Susan says, I used to have good upper body strength and could get up off the floor, no problem. Then COVID hit and I got lazy and lost muscle fast. Yeah, but the good thing is, Susan, is you can get the muscle back. You can get it back. Jennifer says, I need to get over my fear of falling. My fear affects my walking. Yep. Let's see. Hang on, guys. I'm catching up with these comments. So Daniel says the bone was from the lower leg for the Herdle. Okay, so that makes sense. They recycled the bone, I guess, from the part of the leg that was being amputated to use it for the Herdle. That makes perfect sense to do that. We got Doug. He asks, if you tear your quad tendon, what type of exercise should the therapist do on the first visit? So Doug, excellent question. It depends on the severity of the tear. So if you have a tear in the tendon, right? So quick anatomy lesson, guys, you've got your muscle, right? Big, fat, juicy muscle, and the muscle kind of molds into a tendon and the tendon attaches to your bone, right? So the muscle is nice and juicy because it has a lot of good circulation going through it. Your tendons also have some circulation there, but nowhere near as much as the muscle, okay? So when a tendon tears, okay, it takes a little bit longer to heal because it doesn't have as much circulation as the muscle belly. We call that the muscle belly, the actual red part of the muscle, okay? And the same thing with ligaments. Ligaments are the little structures in your body that connect bone to bone. They don't have as much circulation, and that's why these injuries tend to take longer to heal, okay? So depending upon the severity of that tendon tear, they may need you to just keep it at rest and to basically allow that tendon to heal. If a tendon is torn and you're pulling and contracting that muscle, that tendon's never going to heal. Okay, so depending on the grade of the tear, and this is usually something that back in my days of working hardcore orthopedics, I would run it by the surgeon because they are the ones who would know the degree of the tear and say, okay, if it's a grade 1 little bitty tear, then we can do some very gentle isometric exercises, very gentle. And again, clearing it with the surgeon. So Doug, do you know what your surgeon or your doctor said about that? Okay. Number 2, if you have a quad tendon tear, you're in pain. Okay. So usually the first visit with a patient who has an injury is to say, what is the pain factor right now? And how can we get that pain as best under control as we can? How can we address the inflammation and the swelling? So for some folks, it's as simple as providing compression, providing elevation, and giving some really serious ice packs. For other folks, they might need a little bit more. They might need to have the doctor give them an injection of like a cortisone injection to bring down that inflammation a little bit faster. Okay. So once the pain is being addressed, if it's a quad tendon and the surgeon has cleared you or the doctor has cleared you to do gentle muscle contractions, the first thing I would suggest is quad sets, okay? And basically to do a quad set, you put your knee out straight and you activate the quad. So the quad is the top part of your thigh, okay? And you activate it by straightening out the knee, and you just gently start that contraction. And the reason is, A, it obviously helps with getting things, start strengthening things, but it also helps pump out any inflammation that might be sitting on the knee, okay? For most of the leg surgeries that I would see, I loved starting with this exercise because it was a gentle exercise to start with, and it really helps with inflammation and swelling, okay? So I hope that helps, Doug. Let's see. Yeah, and definitely the Herdle procedure would require much more time in the OR, definitely. So Daniel says, being an Herdle amputee and total end weight bearing, I personally find it hard to find a prosthetist. And that's the thing, Daniel. A lot of prosthetists, obviously for the most part in your prosthesis, and not many people are aware of this, your prosthesis is not designed to allow you to put weight on the end of your residual limb. Unless you are a Symes amputation, meaning only your foot was removed, or unless you are a knee disarticulation, you are not supposed to be putting weight on the end of your residual limb, okay? And the third exception to that, Daniel, is those who have had the Herdle procedure, okay? So when a prosthetist goes and makes a traditional socket for a below-the-knee amputee, he or she is making that socket in mind with taking the pressure off the bottom of the limb. So yeah, socket fit, if the person is not trained in this, might be a bit more tricky. David says, I don't have a problem getting up and down off the floor, but I find my prosthetic socket loses air when I am on the floor with grandkids or even attempting other things. Does not give me much confidence in getting back up, an issue I've been continually working on with my prosthesis. So David, I don't know if you saw, I'm going to go ahead and post the link again, David, to the video by Mission Gate on how to get up and down off the floor. Okay. And yes, especially for my above the knee, that can happen where you're on the floor and you lose suction on that socket. So one part of the video, it shows how the person kind of gets on all fours, like on their hands and knees, and then they kind of pick themselves back up again. When I've done that technique with the patient, when they're on their hands and knees, that's usually when the patient can kind of get back into their socket and get that suction going a little bit better because they're putting weight into the knee. So again, David, it's about playing around with the different parts of how you're getting up and down off the floor to see how you can manage that. And everybody does it a little bit differently, but it can be done. It can be done. Susan says physical therapy costs so much that people can't always afford it. I agree, Susan. And a part of that is because insurance companies are not very friendly with wanting to reimburse physical therapists. So they want to, let's put it this way, physical therapy tends to be reimbursed so poorly that the physical therapist has to treat 3, 4, 5, as many as 6 patients at one time in 1 hour, right? So a lot of PTs will either decide not to accept amputee patients because they simply cannot manage, and you can't. You have, with an amputee patient, you have to be one-on-one with the amputee patient, or they have to charge higher copays to meet the deficiency that the insurance decides not to provide. And I have my own clinic here, and I am out of network for that reason alone, because the insurances simply will not reimburse appropriately. So yeah, it's not a perfect system. I will say this, so Susan, folks who have gone and invested in physical therapy services, some of them having to go out of network, some of them have even gone out of state to receive specialized physical therapy services. It's an investment in their health. It's an investment in their quality of life. So it's not a perfect system. I will definitely give you that. So we're getting back to the answers of what is the number one reason for prosthetic abandonment. Megan says fear. William says pain. Stephen says socket. Brett says fall. Susan says fear of falling. Lots of fear, lots of pain. It's socket. Steve, you were right. It's socket fit. Right? And those of you who have been on my show, you know this little thing that I like to say, where if the socket is fitting you well, you could have a wooden foot underneath you and you would walk beautifully, and physical therapy. But if your socket is fit well to you and it's comfortable, then you can walk in just about anything. And I knew this because when I first started out my career as a wet behind the ears therapist, we didn't have microprocessor knees. And all of my patients had basically door hinges and wooden feet. And they walked well, because the prosthetist that worked in the lab down the hallway in my hospital was a genius at fitting sockets, and he made them comfortable. Okay. And this was even before all the fancy liners came into play. Okay. So the number one issue people abandon their prosthesis is socket. Kind of sad. And this is something that I advocate a lot for on the show, and opening that communication with your prosthetist. Those of you who are struggling right now, maybe with your first prosthesis, and you're having to go through socket after socket after socket to get things tweaked, to get things modified, keep going. Keep going, keep working with your prosthetist until you get that fit perfectly. Soapbox over. All right. Poor fitting socket. Yep. Keitha, you got it. John says uncomfortable. Yep. Rhonda says socket fit. Yep. Olga says, make sure you get the right PT though, because my PT trying to teach me a microprocessor knee as a non-microprocessor knee. And yeah, there is a lot of that, guys. There's not a whole lot of us around. One of my colleagues called me a unicorn. I think that was kind of funny. There's not a whole lot of physical therapists around who hang a shingle and say that they are amputee specialists. And yes, you'll find therapists that they don't know the difference between a microprocessor knee and a mechanical knee unless they've had specialized training. I will say this though, if you find a physical therapist who may not have experience with amputees, but they are willing to work with you, you can have a successful outcome. And this is, again, where I put the power in your hands. Okay. If you find yourself in that situation, the first thing you want to do is get your physical therapist connected to your prosthetist. Guys, there is so much I learned about the world of prosthetic componentry because I had good prosthetists to work with that were willing to answer my millions of questions on how devices worked. Okay. And not only that, but to help with gait analysis. A physical therapist, that's our bread and butter, teaching people gait, teaching people how to walk and how to analyze the gait mechanics. Okay. So a physical therapist who knows nothing about prosthetics, they can still analyze your gait. Okay. They might be seeing things and they may not know what they're seeing, but they can analyze it and take that information to the prosthetist. And then between the two of them, figure it out. Okay. And then guys, I've put it out there on several occasions. I've had several of you who have directed your PTs to contact me directly. And I'm only happy to help other colleagues troubleshoot with plans of care. So I'm putting that out there too. Let's see. John asks, my question is, do you have any suggestions on how to make riding the bicycle easier? And I do have some bicyclists here. Johnny V, care to pipe up? for adaptive bicycling. So John, I'm not, you'll have to remind me please if you are an above the knee or below the knee amputee. I was just having that conversation today, that one of my viewers who's a below the knee amputee, he rides his bicycle, two-wheel bicycle, stand up perfectly, no adaptations made except for the pedals, where he has larger pedals so that his prosthetic foot doesn't slip off. A lot of folks, I love to recommend the recumbent bike. I love recumbent bicycles, especially for people who perhaps are not as athletic and they're just trying to get back into their fitness, right? And they're not too sure about their balance. A recumbent bicycle can be a wonderful, wonderful tool. Another thing that we're starting to see a lot more of are adaptive sports organizations, right? And y'all have heard me mention Sportable. It's one in Richmond, Virginia, and they provide all sorts of fun clinics and toys with adaptive sport technology. So if you were to Google in your area adaptive sports, you're gonna find something. Next thing I would recommend, John, is specialized bicycle stores. You know, a lot of these specialty bicycle stores, they might have some of these adaptations and equipment available because it is becoming something you see a lot more. And I know I have some bikers on board, so if you guys want to chime in, that'd be great. Shirley, you did not miss your question, darling. I'm going to answer your question right now. Shirley asks, I was wondering, I am in the hospital for fluid collection and the doctor told me it's the prosthesis. Should I give the new company a try or switch? And the fluid is on the side of the knee. They're letting it resolve on its own. So guys, whenever there's something, you know, that's bothering your body, okay, whether it's because there's too much pressure, there's weakness, the body's response is to create inflammation. It creates an we call it the inflammatory process, right? So that means that fluid will start to collect, excuse me, guys, in an area that it's not supposed to be in, right? And I'm back. Okay. Went down the wrong way. All right. So sometimes, excuse me, you'll see fluid, especially behind the kneecap, behind the patella. Okay. Now, this is what happens with me with water. That's why I don't have anything more interesting in my mug this evening. So Shirley, you mentioned that you were having fluid collecting on the side of your knee. Okay, so that probably means that the prosthesis is either pushing in too hard or rubbing up and down in that area. And yes, that's obviously a problem that the prosthetist needs to look into. Now, guys, problems with prosthetic devices come up all the time. And many people are sometimes quick to jump and blame the prosthetist. But guys, this is part of the process of being an amputee is you have to troubleshoot your socket. You have to troubleshoot your prosthesis multiple times, okay? Even with the best of prosthetists, you might have to go back a couple of times to get things just right, okay? So Shirley, my advice to you would be if you've been happy and satisfied with this prosthetist, then I would take it back to him or her and just say, hey, this is what happened. What are we going to do about it, right? And obviously keep troubleshooting until they get it right. Now, if you take your prosthesis back to your prosthetist and they don't want to work with you and they tell you there's nothing wrong with your socket and this and that and the other, my recommendation would be get a second opinion, okay? And here's what you'll find, Shirley. Either that second opinion will tell you, yeah, there's something wrong with the socket and we're going to fix it so it doesn't push up on your leg and cause you to get fluid collection again, or that second opinion might say, nope, problem's not in the socket, in which case you need to take it back to your doctor and say, all right, we need to think of another solution, okay? So guys, communication here is key. That's what needs to happen. And communication and also patience. Patience in knowing that sometimes with your prosthesis, you may have to go back more than one time to get things just right. But I do say, don't ignore those signs, okay? Don't become a statistic and abandon your prosthesis or put up with a poorly fitting socket, okay? Because that can cause some pretty serious problems down the line. Patricia asks, if I do sitting chair exercises, should I do them with my prosthetic on or off? I am a left above the knee amputee. Great question, Patricia. And this is actually making me really smile because I've been working on this top secret project for a really long time and it's killing me because I just want to blurt out what it is that I'm doing. But I can't just yet. So, Patricia, whenever I work with my patients, whether they are above the knee or below the knee, I always try to see if there's a way that I can modify the exercise so that they can do it with the prosthesis on. Why? Because it's your leg, and I want your body and your brain to accept that this leg is in fact your own. So the more activities you can do with the prosthesis on, the better that acceptance is. And in some cases, right? In some cases, having that leg, the prosthetic leg on, gives you a little bit of extra leverage. So you can actually use that residual limb and engage those residual muscles more. Now, that being said, there's just sometimes where that prosthesis is just not going to cooperate with the exercise that I want to do with my patient. So I'll say, take the prosthesis off and let's do the exercise without the prosthesis. There are so many different ways to skin the cat, okay? You can do so many of these exercises with the prosthesis, without the prosthesis, and targeting the muscle groups that need to be addressed, okay? And that's all I'm going to say about that, because if not, I'm going to start blurting out my secrets. All right. Let's see. Oh, here we go. Thank you, Jamar Brothers. It says, definitely need modified gears for shifting motorcycle. I was in the motorcycle accident, which gave me this gift. However, lesson learned, and I know that even though it wasn't my fault, I wouldn't get back on the bike unless I have a death wish. Yeah. It's never how you ride. It's always the people around you. Agreed. And I used to love motorcycle riding back when my husband and I were dating. He had this really nice little, is it Ninja 500? Little rice rocket. They're a lot of fun, and my husband was a very good and responsible motorcycle driver. But yes, unfortunately, many of the patients that I've had who are motorcycle accident patients, it's because of the other people on the road, which is unfortunate. All right, let's see. Hey, Stephen Tridell. Okay, so Doug says, I don't know the grade, but I see an OCS tomorrow morning. Very nervous. Doug, give me a call. Give me a call tomorrow, and we'll talk. Okay. Yeah, we'll talk. Sorry, guys, I'm a little bit behind on the messages tonight. Oh my, Gage is getting an X3 and extended range Echelon ER. I am so excited. I'd be excited too. That is a seriously sweet setup there. Nice. Okay, Susan, very good question. Susan asks, if the whole point is non-weight bearing, meaning on the end of the residual limb, why does my prosthetist always tell me that the end of the residual limb can sit on the bottom of the socket when I tell him I think I'm bottoming out? Okay, so Susan Darlin, please remind me, I've got mom brain right now, above the knee or below the knee. So the residual limb has to go into the socket all the way, right? But the weight is not being put into it. Does that make sense? And it's a very fine line, because if you're not in the socket enough, you're not going to have a good fit. You're going to have poor suspension. Your alignment is going to be completely off. You're going to have pressure points on your leg. If you're too far into the socket where you are bottoming out and you're feeling the weight on the end of that limb, that's no bueno as well, okay? So one of the old tricks, the old school tricks, is to put a little lipstick mark. I'm not joking. You put a lipstick mark on the end of your residual limb, and then you put your limb into the socket. And if you see lipstick, and then you take your limb back out, and if you see that there's lipstick smudged all the way around the end of that socket, that means you're way too much into that socket, you're bottoming out, and you need to put some socks on, or the fit of the socket needs to be adjusted. Okay, so it's kind of a, yeah, your residual limb needs to be all the way down, but not so much that you're putting weight through it. Okay. All right. Thank you, Steve. Okay, so here's another one of my fellow PTs. Kristen says, as a PT provider, I will agree it's really unfortunate that insurance does not reimburse better for physical therapy services. I think it's a major problem in our healthcare system. We have to change. I dream of the day when insurance companies finally realize investing PT is an investment in the health and well-being of everyone and will save money in the long run if they reimburse for PT from the beginning. Off soapbox now. Well, thank you very much for that soapbox, Kristen. It's good to hear someone else besides myself talking about that one. And Stephen, you mentioned about the reimbursement that your insurance did for physical therapy. That's actually an unusual rate. That's an unusual rate. Yeah, that means you have good insurance. Very rare. Jeffrey says a lot of times it's even harder to find a good physical therapist for bilateral above the knees. Stubbies to knees is a hard, long, tough process. It is, Jeffrey, it is. And I will say that when I had my first bilateral above the knee patient eons ago, it was definitely a cold sweat moment where I was going, okay, I've been seeing a bunch of unilateral amputees above the knee and below the knee, but first bilateral, okay, we can do this. And even among the experienced amputees, experienced physical therapists, it is an additional challenge. But I'll tell you what, Jeffrey, when you find one, you'll find that they are very passionate about what they do. And Jeffrey, you give me a call, man, if you need any help. Okay, thank you, David. You are so kind. So Achilles is a great adaptive sports organization that has chapters all over the world that advocates for cycling. There we go. All right, guys, I think I have read through. Wait, one more question. Hang on. There's Ashley's random question. Why is it sometimes I can tell there is a height difference and sometimes I can't? For example, last week I went in for a tune-up after seeing my PM&R doctor and needed to follow up with my prosthetist so he could order my supplies. He noticed my gait was off. He added a 1/4 inch height. I didn't even notice. In the past, I've gone to him over 1/8 of an inch that I could tell. And actually, I'm chuckling right now because I used to remember when I had a prosthetist down the hallway in the hospital I worked at, I would, basically stick my head out in the hallway and go, Steve, I need a height adjustment. And he'd come in and he's just like, it's 1/8 of an inch. And I'm like, yeah, I know, but adjust it. So we always had that kind of thing. So yes, and some people that they are extremely sensitive to height difference, and a 1/8 of an inch to them feels significant. And other folks, they can go around with as much as 2 inches in difference, and that's what they're used to, depending, especially if that's what they were like before their amputation. So Ashley, I think in your case, you may be a little desensitized to the height difference just because you're becoming so much more active and you're so much better with your movement, that you're probably compensating. Not to mention, Ashley, if you're changing your footwear from one day to the next, that means the height difference is, having these little changes during the different days. So you probably become accustomed to it, but it's a good thing that they caught it. Okay. Oh yes, we have to give a shout out. Robin says, before you close, I'd like to brag on my son, who as of today is a graduate of the University of Pittsburgh School of Rehabilitative Medics, Prosthetics, and Orthotics program. He is starting his residency in Scottsdale, Arizona, future prosthetist, proud mom. And guys, this young man, he doesn't know it yet, but man, Robin, I'm going to be dragging Isaac onto the show at some point. He's going to get put into the hot seat. It's always a joy to see a new clinician who's going to be an amazing clinician, just an amazing clinician with this young man. So congratulations, Isaac, to you. Congratulations to you, Robin, because behind every successful son or daughter, there is a very proud and exhausted mother. So congratulations to you and Wayne. All right. All right, guys. So we're going to go ahead and wrap it up for this evening. We are, yes, wrapping it up for this evening. I need sleep right now. Okay, guys, if I missed your question, I know there was a few comments that went through that I didn't get to go to tonight. You can always, guys, please sign up for my email subscription on my website. I posted it right there. And on my website, you can also send me questions that go directly to my email. I check it every day. I answer every single question that comes to my email inbox. So please, guys, don't be shy. Send me your questions. If you have the chance, guys, go visit my Facebook page where I posted that video that my team put together so beautifully. Feel free to share it out. I would really appreciate it, just to let people know what it is that I do and that I am here. All right, guys, on that note, I'm going to go ahead and sign off and go to sleep. So I'll see you guys same bat time, same bat channel next week. God bless.